Ah, yes. I'm here.
Uh,
Yes,
Good
Prasanna.
evening. Good evening, and welcome you all for the third class on this focus session of ultrasound. Today we will be discussing about the cardiac echocardiography (IVC) and the fast scan. This is the third class of this series, initiative by Neuro Classroom ISNAC. So we welcome our moderators. Dr. Ponniah is there today. As usual, he is the fulcrum of our class. Dr. Manish is there, the expert in the ultrasonography, and Dr. Niraj will be presenting to us today the important aspects of the cardiac examination. Dr. Niraj, welcome and over to you.
Good evening, everyone. So, as we have discussed in the first class, that basic principles of ultrasound, basic knowledge. In the second class, we have discussed the application of ultrasound related to lung pathology. And today, the third session of our ultrasound class, that is basic echocardiography and inferior vena cava examination and the fast examination in trauma patients. So, all the things we are going to cover today. So, let's start with the case scenario. A 25-year-old male with a history of RTA comes in the casualty with BP of 60 by 40. So, a patient is in naturally in shock. So, I would like to proceed. So, as a management protocol of ATLS guideline, first we have to follow this ABC pathway, that is airway breathing circulation. Patient is intubated and put on mechanical ventilation. And in the C part, according to ATLS, we give 2 liter, 1 to 2 liter of renal lactate on normal saline to increase the BP. But in spite of doing that, the blood pressure is not rising. So what may be the region? So this is many of us faces such situation that the patient is in shock, and fluid resuscitation is not the only answer every time. So naturally, why the patient is not responding to fluid resuscitation? The reason is there are different kinds of shock. Okay, no, although in trauma settings the most common reason for shock is hemorrhagic shock, but patient might be suffering from cardiogenic shock. Patient might be suffering from this obstructive type of shock like pneumothorax, like a pericardial tamponade. And in that condition, the fluid which we are giving is harmful. Suppose patient is suffering from this pericardial tamponade. The fluid resuscitation is not the answer. So we have to do pericardiocentesis to save the patient. And take an example of patient is suffering from cardiogenic shock. In that condition, also fluid resuscitation will be harmful to the patient. We have to give inotropes. So according to the type of shock, we have to plan our further management. But in the emergency condition, when patient is in shock, what is the reason of what is the cause of shock? It is something we have to evaluate quickly, and for even for the most experienced person in either in ICU or OT or emergency, it is very difficult to find out what is the cause of shock. The traditional way of doing physical examination, taking history, will be misleading in such situation. So ultrasound have an answer here. Suppose we patient in shock, you just keep your cardiac probe above the chest, you can see the pericardial effusion. So you come to know that patient is suffering from a tamponade. Okay, suppose in other condition the contractility is reduced, so you come to know that patient is suffering from cardiogenic shock. So it will give inotropes. So ultrasound helps in diagnosis, making the diagnosis very accurate, so that clinician have the confidence to move further management. So objective of this talk is to first of all to discuss the what are the basic four views of the basic echocardiography. And there is a very famous Rust protocol for management of shock patient. And then in the Rust protocol also we have to integrate all the cardiac findings, the lung findings, and inferior vena cava status, and also do fast examination. So this completes the basic echocardiography and Rust protocol for the management of shock patient. So after that, we will discuss in brief that how this stroke volume is estimated or calculated by the by some simpler techniques. So first of all, we are going to start with the basic echocardiography. Remember, we are not an cardiologist, and we are not doing advanced echocardiography. We just want to do a focused echocardiography. That means we have certain focused clinical question in our mind, and we just want the answer of those focal questions. We are not doing comprehensive echocardiography. So what are those focal questions? We are interested to know whether the heart is beating or not. If the heart is not beating, you have to suspect cardiac arrest. Okay, sometimes it is difficult to diagnose even cardiac arrest. So you just have to put your probe and see whether the heart is beating or not beating. First question. The second question, we have to see what is the status of pericardium. Just see is there any pericardial effusion, so that you can diagnose the tamponade effect. Third point, we have to know what is the status of left ventricular function. What is the contractility power. And the fourth question, is there any right ventricular strain pattern, so that you will come to know about the pulmonary embolism. So these are the basic question. We just want answer of this basic question, so we can come to an accurate diagnosis and initiate our management. So these are the four basic views for doing basic echocardiography. First, you can see this is remember, this heart is situated obliquely in the chest. It is not situated at like a straight line. It is situated obliquely in the chest, with the apex pointing towards left hip. So suppose this is the one plane, that is long axis plane, blue color. Sometimes it is called sagittal axis. And this is second plane, that is short axis plane, that is transverse axis, and this is the third plane, that is called apical plane, purple color. So that is the coronal axis. So these are the three axes, and these are the four views. So four basic views are very important in the initial part. So first is parasternal, this green color parasternal long axis. So you just have to keep your probe here and you will obtain this image. This is parasternal long axis. And after that, you have to rotate your probe to obtain the short axis view. Then the third is apical four chamber view. Then this is the apical four chamber view. Then the last and the fourth view is the subxiphoid view. So these are the four basic views. We have to obtain these four basic views to do basic echocardiography. Remember, we are in the first class we have discussed there are three kinds of probe. One is linear probe, then curvilinear probe, and third is cardiac probe or phased array probe. So we are doing basic echocardiography. So we are using phased array cardiac probe. And regarding orientation marker, we have just discussed that orientation marker for the cardiac probe in the upper right side of the patient. So starting with the first view. This is parasternal long axis view. So patient is in supine position, and you have to keep your cardiac probe over the third, fourth, and fifth intercostal spaces on the left parasternal margin. So as the name states, parasternal means left parasternal, and this is long basis. You are seeing the heart in the long axis. So you have to keep your probe over the left parasternal margin, third and fifth intercostal spaces. And one important thing, what should be the position of orientation marker. Orientation marker is pointing towards the right shoulder. Remember, majority of the people are using this orientation marker here. Then, but in some textbooks or in some article also, you will find this orientation marker in a different direction or just opposite. So here, one thing I want to clear that, so if you are using your screen marker on the this cardiography on the upper right side, then in this presentation we are assuming this assumption that our screen marker on the upper right side, and according to that we have to keep the orientation marker. But remember that some people are doing just opposite of that. But to avoid any confusion, I'm just using this convention. But remember, sometimes it is confusing. But the thing is that whatever convention you are using, you have to obtain the same image. Okay, image should be same on the screen so that everyone can interpret it, the uniform thing. So this is the you are seeing the longitudinal axis of the heart. So that is the view you will obtain here. So that was the image acquisition, and now we are going to describe this. This is image interpretation. How will so first thing I want to clear that in majority of the people, right heart is most superficial in location. So heart is closer to the chest wall, so it will be closer to the probe also. So that means right ventricle will be situated in the upper part of the screen in the most of the views. So this is parasternal long axis. You start with the right ventricle in the top part of the screen. So remember, you will not see the right atrium. After that right ventricle, you just see the left ventricle. Okay, so this is the majority of the left portion of the image occupied by this left ventricle. You will not see this left part of the this apex of the left ventricle, but this much of the left ventricle you can see. After that, in the right lower portion, you have to identify this left atrium, and between the left atrium, the left ventricle, this is the mitral wall, anterior and posterior curves. Then you have to identify this left ventricle outflow tract and the aortic wall. And this white hyperechoic pericardium that is surrounding the heart. And last but not the least, this is the descending cut section of the descending aorta that is behind the pericardium. So that is the image interpretation. So what is the use of this? This view is very important to assess the left ventricular contractility. Okay, if this there is a good amount of percentage shortening of this ventricular cavity, that means the good contraction. And another way of assessment is this mitral wall leaflet movement. If there is a good contraction, this leaflet will just touch this interventricular septum. We will see later how the contractility is assessed. Just we have a video, first video for parasternal long axis. This is parasternal. This is parasternal long axis view. First of all, we have to identify the bright hyperechoic line surrounding the heart is pericardium. After that, in the superficial portion of the screen, we can see the cavity of the right ventricle. After that, in the left portion of the screen, we can identify the cavity of the left ventricle. And in the lower right portion of the screen, we can identify the left atrium. And in between the left atrium and left ventricle, we can see the mitral wall. After that, left ventricle outflow tract can be seen. And in between the left ventricle and left ventricle outflow tract, we can see the aortic wall. And in the lower portion of the screen, we can identify the cut section of the descending aorta that is situated outside the pericardium. Now we come to the parasternal short axis view. So this is parasternal short axis view. Remember this, the patient is in supine position, and you have to rotate the probe from the parasternal long axis to the right angle clockwise, so that now the probe marker is directed toward the left shoulder. In the parasternal long axis, the probe marker was directed towards the right shoulder. Now in the parasternal short axis view, so this is directed towards the left shoulder. And this is the image you will see. So remember, we are cutting the heart in left ventricle part. So we will visualize the right ventricle and the left ventricle. In the upper left portion, we will see the cut section of right ventricle, and in the lower right portion, we will see the left ventricle. So we are at the level of, first of all, we are at the level of mitral wall. Then the mitral wall gives an appearance of the fish mouth appearance. Then if you lift your probe slightly in upward direction, you will reach at the aortic wall level. That aortic wall you can see, that is a Mercedes Benz sign. And if you tilt the probe slightly lower side, you will reach at the papillary muscle level. So there are three levels. At the mitral wall level, there is a fish mouth appearance. This is the aortic wall level. So we have a video for that.
This is parasternal short axis view of the heart. Here both the ventricles can be seen in their short axis, that is cylinder cutting cross section. First of all, we can see the cavity of the left ventricle in the lower right portion of the screen. After that, we can see the cavity of the right ventricle in the upper left portion of the screen. This view is very important to assess the overall contractility of the left ventricle and also the right ventricular strength pattern. Here we can see that there is a good amount of contractility of the left ventricle, and there is a good amount of squeezing of the endocardial walls during the systole period of the left ventricle.
Now we come to the our third view, that is apical fourth chamber view of the basic echocardiography. Here the patient preferably should be made left lateral position, but sometimes in the trauma setting, if it is not possible to make the patient left lateral position, you can obtain this view in the supine position also. So this is, you have to keep your probe at the fifth intercostal space just below the nipple, also called PMI, means point of maximum impulse. Now, the marker is towards the 3 o'clock position. And you have to aim. Aim means direction of the probe. Probe is looking towards the right shoulder. Okay. So this view is very helpful to assess the global contractility of the ventricle and to compare the relative size of the right ventricle compared to the left ventricle. And you will acquire this image. So we have, first of all, we can see the apex of the heart, because the apex of the heart is very close to the probe. So a structure which is close to the probe will appear on the top of the screen. That is the one principle. So first of all, you can see this is the upper right portion. So that is left ventricle. In the screen, upper left portion of the screen, cavity of the right ventricle, and the interventricular septum in between the two ventricles. And there are two atrium just below the respective ventricles. And between the left atrium and the left ventricle, we can see the mitral wall. And similarly, between the right atrium and the right ventricle, we can see the tricuspid wall. And lastly, we have to see that this is bright hyperechoic line, that is pericardium, totally surrounding the heart. So overall, this view is to assess the contractility and the relative size between right and left ventricle. Normally, the size of the right ventricle is about 2/3 of the left ventricle. So we have a video for apical fourth chamber view.
This is apical 4-chamber view of the heart, and as the name suggests, the apical portion of the heart is in the superficial portion of the ultrasound screen, and all the 4 chambers can be seen in this view. First of all, we can see the cavity of the left ventricle on the upper right portion of the screen, and the cavity of the right ventricle in the upper left portion of the screen, just adjacent to the left ventricle. And also we can identify the interventricular septum in between the 2 ventricles. After that, we can identify the left atrium just below the left ventricle and the right atrium just below the right ventricle. And after that, we can identify the mitral wall between the left ventricle and the left atrium, and the tricuspid wall between the right ventricle and the right atrium. This view is very important to assess the overall contractility of the left ventricle, and also to assess the relative size of the right ventricle compared to the left ventricle.
Now we are at the subdivide view of the basic echocardiography. This is the 4th view. So remember, this is something unique, because in all the 3 views, apical chamber or short axis or long axis, we are seeing the heart through the chest. But in the subdivide view, we are seeing the heart through abdomen. Okay, here we are keeping the probe in the upper part of the abdomen, that is the subdivide area, and the liver comes between. So we are seeing the heart through the abdomen via liver. So liver will be just on the top part of the screen, because it is just superficial to the probe. And remember, we have to just make this probe tangential to the abdominal part. So we have to tilt the probe in a downward direction. Then we can see the heart. And of course, if you are using this cardiac probe, then the probe markers would be on this left side of the body. And here, the one thing is special, that you can use your curvilinear probe also. So if you are using curvilinear probe, then probe marker should be on the right side of the patient. So in this image, you can see we are using this cardiac probe. So marker is towards the left side. And the aim of the probe, we are seeing it towards the left shoulder. Okay. So the main application of this subdivide view is to see the pericardial effusion. And there is also a concept of ultrasound guided resuscitation. That means if the resuscitation is going on, the clinician are doing CPR at this stage, CPR at this area. So in that condition, nowadays there is a concept that you can just view the heart through the subdivide area and see what is the region of this cardiac arrest. When there is an interruption in the chest compression during the CPR period, and the clinician can visualize the heart through this subdivide area. So subdivide is very useful nowadays for the ultrasound guided resuscitation. So we have a video for this is a subdivide image. So image interpretation is right ventricle in the superficial portion of the image, and the liver comes in between. And just below the liver, you can see this left ventricle, and the respective atrium just below the lesser respective ventricle. So this in this view, you have this bright hyperechoic line is very important to recognize, because this is the pericardium, and if there is a fluid or any echoic area within the pericardium, that means there is a pericardial effusion. So we have a video for subdivide view also.
This is subdivide view of the heart. In the top portion of the screen, we can identify liver, which acts as a acoustic window, and right ventricle can be seen just below the liver, and the left ventricle can be seen just below the right ventricle. Here we can see that the left ventricle is more muscular than the right ventricle. After that, we can identify the right atrium that is situated left to the right ventricle, and also we can see the left atrium which is left to the left ventricle. And lastly, we can see the bright hyperechoic line surrounding the heart is pericardium.
So we have completed the 4 views of basic echocardiography. Paracental long axis, short axis, apical 4-chamber, and subdivide. This basic understanding of all the 4 views are very useful. And always remember that in every patient you cannot. It is sometimes not possible to acquire all the 4 views. So sometimes one view may be missing, or in some patients one view is not appropriate. So remember, heart is a 3-dimensional structure, and you are seeing the heart through the various 2-dimensional cross sections. So you have to assimilate all the 2-dimensional cross section images to imagine a 3-dimensional picture of the heart in your mind. So you have to assimilate all the images in your mind to imagine a 3-dimensional structure of the heart. So now we are discussing the RUS protocol. RUS protocol means if the patient is in shock, so how to quickly know what is the region of the shock, or how to manage in a prompt manner. So RUS, full form of the RUS is rapid ultrasound in a shock patient. This is a 3-step procedure that is easily learned and quickly performed. So one by one, the first step is to see what is the status of the heart. So this was described by the Philippe Pereira in the Ultrasound Clinic Journal in 2012. So this protocol first described what is the status of the heart. Means heart, he had described this as a pumping activity. And the second step, we have to assess the tank. Tank means whether the blood is accumulated in that part. That means inferior vena cava, and the third step is to identify the major blood vessel, major like abdominal aorta or femoral veins. So in the first part, in the first step, assessment of the heart, we have to see what is the status of pericardium. So we have to quickly assess the pericardium and diagnose whether the pericardial effusion or tamponade is present or not. In the second part, we have to assess what is the function of the left ventricle. So that is called squeezing of the pump. So in the third part, we have to understand is there any right ventricular strain pattern. In that condition, right ventricle will be dilated. That's a signal of pulmonary acute pulmonary embolism. In the second step, we will see what is the status of the tank. Means the blood where the blood vessel is blood is accumulated. So we will see what is the status of IVC, inferior vena cava, whether it is full or whether it is empty. So if the IVC is empty, that means there is a signal towards the hypovolemic shock. If the IVC is full, that means there is no requirement of the fluid, and we have to search for the other causes like obstructive shock or cardiogenic shock. Then the leakiness of the tank means whether there is any rupture of the blood vessel, so that the blood is accumulating in the pericardium or hemiperitoneum. So this is very useful examination that is called the fast examination. So we will discuss in detail in the coming slides. Then that is called tank compromise, third point. That means there is a pneumothorax. Tension pneumothorax is an emergency condition. We have to just quickly diagnose this pneumothorax. And the fourth point in the tank is fluid overload. So if there is an overload, that means pulmonary edema. So this two things. This pneumothorax, and the pneumothorax is the example of this obstructive shock. And you just have to put these two part of the lung scanning, which we have discussed in detail in the second class. Just I am summarizing that to diagnose the pneumothorax. So we have to use this linear probe. We have to keep this probe on the anterior part of the chest, and the sliding sign will be absent, and then this the lung point will be absent. And the lung point is the diagnostic feature of this pneumothorax. And once you have diagnosed this pneumothorax, you just have to do the needle compression and the chest tube drainage. And this tank overload is also an example. Suppose in the cardiogenic shock, heart is not able to pump. There, because of this increased hydrostatic pressure, there may be development of cardiogenic pulmonary edema. In that condition also, you just keep your probe over the chest and you will see the B lines. So if the bilateral homogeneous B lines you are seeing quickly, you can see that say that there is a cardiogenic type of shock or cardiogenic pulmonary. So these two things we have discussed in detail in the second class of the lung ultrasound. So I'm not going to cover this thing in today's class. And the third step of the RUS protocol is about the pipes. Pipes means major arteries and major veins. Like two important things which are common in the emergency condition, not so common, but we have to recognize that is one is abdominal aortic aneurysm and the aortic dissection. These are not common, but very, very lethal. So you have a strong suspicion in your mind that patient might be, this might be one reason for the shock. And the last part of RUS protocol is to scan the popliteal vein and the femoral vein to see any evidence of this thrombosis. That's an indication of pulmonary embolism. So these are the very simple steps, first, second, and third, so that you just quickly perform and you have a good idea that what is the region of the shock, and then only you can proceed further in a more confident manner. So first step is the assessment of heart. So heart is also called pump because of pumping activity. So we have already discussed the assessment of, we have to use this for all the four views, parasternal, long axis, short axis, pericardial fourth chamber, and subdivide view, to diagnose what is the condition of the heart. So remember, we are doing basic echocardiography, any focused echocardiography. First of all, we are not doing the comprehensive or advanced echocardiography. We have certain clinical question in our mind, whether the heart is beating or not, whether there is evidence of pericardial effusion or tamponade. Third is whether the what is the contractility of the status of the heart. That means either any cardiogenic shock. Fourth, we have to see the what is the status of right ventricle. Is there any right ventricular strain pattern or not? So that we will can diagnose the acute pulmonary embolism. So we have only clinical question in our mind, and we want quick answer of those clinical questions. So first of all, the first step in the heart is assessment of pericardium. Just to see the pericardium and see whether there is any evidence of pericardial effusion or not. This is the parasternal long axis view, and you can see that this bright hyperechoic line. You concentrate on this bright hyperechoic. So you in this image you can see that there are two layers of the pericardium, and there is an anechoic area between the two layers of the pericardium. That is the sign of pericardial effusion. So you just quickly perform this within this image within seconds. So there is an anechoic area between the two layers of pericardium. And remember, it may be pericardial effusion may be in a small amount, or in maybe large amount. In a small amount, there may be a hypoechoic stripe. But in a larger amount of pericardial effusion, the anechoic area will be totally surrounding the heart. So it may be a small or it may be large. Or you have to also understand that There is pericardial effusion may be quickly assimilated, or there may be chronic accumulation of the fluid. So chronic pericardial effusion is not so much dangerous because heart is adaptable for that. But in case of acute rise in pericardial effusion, that is very dangerous situation for the heart, and this may be the cause of shock. And one reason that after diagnosing this pericardial effusion, you have to see the status of the IVC. So IVC will be dilated. So you can see that now this is a severe kind of pericardial effusion. The fluid is totally surrounding the heart, and you can see that the chambers of the heart starts collapsing. So remember that right side of the chambers and the left side of the chambers. Left is the left ventricle. That left ventricle is very, very strong because it has to pump against the highest systematic pressure. Right side of the heart is not so strong because it has to pump against the low pressure circulation of the pulmonary circulation. So if the pressure within this pericardium is rising, it just starts collapsing this right side of the heart. You can see that right ventricle is collapsed during the diastole period. So this is very unique feature in the cardiac tamponade. So you can see that pericardial effusion totally surrounding that, and in the diastole period, this right ventricle is so this diastolic collapse of the right ventricle is very important and very unique feature of the severe amount of pericardial effusion. So this is regarding the physiological aspect of the tamponade. Remember, pericardial effusion is the ultrasound diagnosis, while tamponade is the clinical diagnosis. Okay. So why the tamponade is so much dangerous? Because in the tamponade there is an increased pressure within the sac, and that compresses the heart and impaired the filling of the blood. So heart is not able to fill up with the blood. So naturally the cardiac output will decrease. That is why this tamponade is very dangerous regarding the pathological point of view. So remember, if you remember this clinical diagnosis of tamponade is characterized by Beck's triad, that is hypotension, raised JVP and muffled heart sound. This hypotension, raised JVP and muffled heart sound. These are the three classical Beck's triad signs. So, but these classical signs are seen only in 50% of the cases of tamponade, and moreover, these clinical signs are very difficult to appreciate. So you can imagine the cardiac tamponade is a very, very emergency condition. Patient is developing shock and patient may die soon. And if a clinician wasting his time to find out these clinical signs, which are not present in all the patients, so how much these clinical signs are misleading in such situations. So solution is you just have to keep your probe over the chest, and you can see the pericardial effusion all around, and that's the region of the this tamponade. And you in that condition you just have to do pericardiocentesis immediately, and you can save the life of the patient. Remember that regarding pericardiocentesis, this is life-saving procedures, and here also the ultrasound have a role. The pericardiocentesis, you can use ultrasound to find what is the optimal site of needle insertion. Okay, and the traditional approach is a subdivide approach for the pericardiocentesis, but that is the classical approach. But if you using this ultrasound for needle insertion, you may find parasternal or apical view is also very, very useful for that. So we have a first video for this pericardial effusion.
This is another clip for pericardial effusion. And we are in a apical 4-chamber view. First of all, we have to recognize the bright hyperechoic line, that is pericardium. And you can see there is huge amount of anechoic area that is totally surrounding the heart, that is severe amount of pericardial effusion. And in addition to that, during the diastole period, you can appreciate there is a diastolic collapse of the right ventricle.
We have
This
a
parasternal long axis view. First of all, we have to recognize bright hyperechoic line, that is pericardium. And within the pericardium, we can appreciate hypoechoic area, that is pericardial effusion. Now the same thing we can also see in apical four-chamber view. Here also the bright hyperechoic line is pericardium, and within the pericardium there is hypoechoic zone, that is pericardial effusion.
So we have seen the pericardial effusion, that is a small amount of effusion, and the larger amount of effusion that is totally surrounding the heart. In that larger amount of pericardial effusion, you can see the diastolic collapse of the right ventricle. Now, in the second part of the pump is to assess the contractility or the squeezing power of the left ventricle. Remember, in the Russ protocol, we are just seeing by the visual estimation, or that is eyeballing method. Because of we have to perform this in a quick manner. So this is the visual estimation of the contractility power of the heart. And so we are seeing what is the percentage change chamber size from the diastole to systole. So the left ventricle is contracting. So what is the percentage? If the percentage change size of the left ventricle is good from the diastole to systole, that is the good contractility. So we are seeing the left ventricle wall thickening. If the thickening is good, the contractility is good. And another very interesting method of assessing the contractility is to see the movement of the anterior leaflet of the mitral wall in the parasternal long axis. So, so you can just by eyeballing method, you can just with it comes with naturally with experience that this is the good contractility, and this is the intermediate contractility, and this is poor contractility. Poor contractility means the left ventricular wall is not moving. And this mitral wall anterior leaflet is not touching towards the interventricular septum. So this visual estimation is also very, very helpful compared to this proper calculation of the contractility. You can see this in this picture. This is a good contractility. This is a poor contractility. So this is the first picture is the picture of the diastole. And the second picture is the picture of the systole. This is parasternal long axis view. See that the change in chamber size from the systole to diastole is good. Okay. And that's the sign of good contractility. So what is the percentage change in chamber size from the diastole to systole? By visual estimation. So you can have an idea about the good contractility. Naturally, if you are seeing this type of image, that this is the diastole period. So this is the chamber size in the diastole, and this is the chamber size in the systole. You can just see that there is not so much change in from the diastole to systole. So that is the sign of poor contractility. So we have a video for good contractility.
This is slow motion video of the parasternal long axis view of the heart. This is to show the movement of the anterior leaflet of the mitral wall for assessment of contractility. Here we can see that during the initial ventricular filling phase, the anterior leaflet of the mitral wall is vigorously touching the interventricular septum, and that is a sign of good contractility.
So you have seen that by seeing this anterior leaflet wall motion, you can assess this contractility. That is very, very interesting. So during the vent, if you remember just physiology of the heart, during the ventricular filling from the right atrium to this left atrium to left ventricle, the ventricular filling. Initially, there is a huge amount of blood is going from the left atrium to left ventricle. That is the ventricular filling phase of in the initial part. So this mitral valve opens and touches the interventricular septum. And in the last part of filling period, there is arterial contraction, and rest amount of blood is going from the left atrium to ventricle. So this movement of the left, this wall touching the ventricle is very, very important parameter to assess the good contractility. So we have a video for poor contractility also.
This is to show the poor contractility of the heart and the low ejection fraction by visual estimation. First of all, we are seeing the parasternal long axis view. Here we can clearly see that very small percentage change in chamber size from the diastole to systole, and also very little movement of the cardiac wall during the cardiac cycle, and there is little movement of the anterior leaflet of the mitral wall, and it is not touching the interventricular septum during the ventricular filling. And the same thing we can also appreciate in parasternal short axis view. Here also we can clearly see that very small percentage change in chamber size from the diastole to systole, and also very little movement of the ventricular wall during the cardiac cycle. Now we are in apical four-chamber view. Here also we can clearly see that very small percentage change in chamber size from the diastole to systole, and there is very little movement of the ventricular wall during the systole period, and chamber is almost dilated. That is a sign of poor contractility of the heart.
So in the third part of the Ross protocol, we are seeing the right ventricular strain pattern, that is the diagnosis of pulmonary embolism. So we have to we have to understand the left ventricle is high pressure system. So the thickness of the left ventricle is more compared to the right ventricle. But in the case of pulmonary embolism, the right ventricle is dilated. So normal size of the right ventricle is about 2/3 of the left ventricle. Or also you can say the 0.6 ratio is 0.6 to the left ventricle. But in case of right ventricular dilatation, the right ventricle becomes equal to the left ventricle. And if the right ventricle is size is more than the left ventricle, there is a sign of severe dilatation. So remember, if there is a pulmonary artery obstruction because of any reason, take an example of acute pulmonary embolism, there may be acute dilatation of the right ventricle. So right ventricle is dilated. You can see the right in the parasternal long axis view. This right ventricle is dilated, and the size is more compared to the left ventricle. Another sign is we have to assess the status of interventricular septum. So naturally, if the right ventricle is dilated, then this septum will be deflected more toward the left ventricle. So this is right ventricle, this is left ventricle. Normally, it is bowing towards the right ventricle, but in case of dilatation, it is bowing towards the left ventricle. And sometimes the shape of the left ventricle becomes the D-shaped shape. You can see the D-shaped left ventricle. And in some cases also you can see the thrombus in the right atrium. And once you have seen that there are evidence of pulmonary embolism, and you are suspecting one of the region for the shock patient, then you have to scan this leg area, and you may find DVT sign positive in the popliteal or femoral veins. So we have a sign for this right ventricular strain pattern video, pulmonary embolism.
This is parasternal short axis view of the heart. showing the right ventricular strain pattern classically seen in acute pulmonary embolism. We can clearly see that right ventricle is dilated and the size of the right ventricle is more compared to the left ventricle. We can also see that interventricular septum is deflected toward the left ventricle and there is a paradoxical septal wall motion. We can also see that D sign, that is D-sept chamber of left ventricle.
Now, in the case of pulmonary embolism, there is an important sign that is McConnell sign. Sometimes you might find this sign. The McConnell sign is, if you see closely, this right ventricle, this apex is performing in a normal condition, but this right free wall is akinetic. So McConnell sign is akinesia of the right free wall and the normal function of this apex of the right ventricle. That is called McConnell sign. You can see that right ventricle is dilated. There is akinesia of the free wall, but the apex is contracting good. So there is one soft clip for McConnell sign.
This is McConnell sign characterized by akinesia of the mid-free wall of right ventricle.
That is a very short clip for that. So we have completed our first step, that is assessment of heart or assessment of pump. Now in the second step, we have to assess what is the status of tank. Mainly we have to see the IVC examination. Then after that we will do first examination. So in the tank part, we have to see that in the lung examination, we have already covered that we have to diagnose this pneumothorax and pulmonary edema. And for this IVC examination, we have to we can use either this curvilinear probe or the cardiac probe. And if you are using this curvilinear probe, then the markers should be in the cephalic direction. And you have to keep the probe in the subxiphoid region after identification of the heart in the subxiphoid view, and make the probe in the longitudinal direction. So we will obtain this image. So you can see that this is the superior aspect of the body, and so this is the heart, and this is the inferior aspect of the body. So you have to find this IVC draining into the heart. Okay. Then sometimes you may also find this hepatic vein draining into the IVC. Remember, in the longitudinal axis, you may find the IVC if you are tilting the probe slightly in the right direction. But if you are tilting the probe in the left side of the patient, you may find abdominal aorta also. Okay. So you have to remember that. Then you have to differentiate between IVC and the abdominal aorta. Naturally, abdominal aorta is more pulsatile and more thicker than the IVC is draining to the heart, and it is not so much pulsatile. If you have any confusion, you can use this color Doppler mode also. But IVC you have to recognize. So there is a concept of inspiratory collapse of the IVC. Remember, in a spontaneously breathing person, during the inspiration phase, there is a negative intrathoracic pressure. And because of negative intrathoracic pressure, there is increased venous return from the abdomen to the chest. So the IVC diameter naturally will be decreased. So this is the inspiration phase. You can see that during the inspiratory phase, there is a decrease in the diameter of the IVC. This is another picture. This is expiratory diameter. There is inspiratory diameter. This is very simple physiology to understand, but in a spontaneously breathing patient. And you can augment this finding in the when the person is sniffing. Sniffing is the forceful inspiration. So this phenomenon will be augmented. Now, CVP, what's the relationship of IVC for the estimation of CVP? There are several literature which are suggesting that CVP is not so much useful today, but so IVC is also a very good marker for how much CVP is there in the patient. So we can have a rough estimation. This is suppose take an example of this. If the IVC diameter is less than 2 centimeter, and if there is a collapse more than 50% during inspiration, okay. So I've already told that during inspiration there is a collapse of the IVC. So first criteria is if the IVC diameter is less than 2 centimeter, and if there is a collapse of more than 50%, that roughly correlates to CVP less than 10 centimeter of water. This is one scenario. Taken another scenario. If the IVC diameter is more than 2 centimeter, that means it is pretty full. And if there is collapse of less than 50%. So roughly, there is rough estimation that CVP more than 10 centimeter. So this is about rough idea that what is the size of the IVC, what is the collapsibility of the IVC. So we have to measure the IVC diameter for that. So diameter of the IVC can be easily measured in the M mode. M mode is more suitable for measurement of the IVC. This is the 2D picture, and after pressing this M mode, you will get this cursor. So cursor should be placed 2 centimeter from this IVC atrium junction. First criteria, and another criteria, you can also place this cursor just beyond this hepatic junction of the hepatic veins IVC. So these two criteria, you can just place your cursor in the IVC, and this is the M mode tracing of the IVC. So you can see that this is the inspiratory phase in which the IVC diameter is less, and this is the expiratory phase of the IVC. So this is a spontaneously breathing patient I am talking about. So naturally there is a decrease in the diameter. So how much decrease in the diameter? How much there is a collapse? So we can estimate by the collapsibility index. So what is this index? So index is calculated by the maximum diameter during expiration minus minimum diameter during inspiration divided by the maximum diameter. So this gives an idea about collapsibility index, also called Cavell index. So all the things we have discussed in the spontaneously breathing patient. Now come to the mechanically ventilated patient. So situation will be just reverse. In the mechanical ventilated patient, during the inspiratory phase, when the ventilator is pumping the air in the chest, then IVC will be dilated, and during the expiratory phase, the IVC will be collapsed. So just there is a reverse in the mechanically ventilated patient compared to the spontaneously breathing patient. So in here, there will be a distensibility index. The formula will be same. Maximum diameter minus minimum diameter divided by maximum diameter. So this distensibility index is very useful for a critical care physician for seeing the fluid responsiveness. This is a very good guide if you want to give fluid to the patient. If this IVC diameter distensibility index is more than 12%, or some literature suggests 18% or 15% also. If it is this index is more than 12%, that's a rough indication that you can give the fluid, because patient is fluid responsive. So we have just covered the IVC assessment part. Then in the second part of the tank is fast examination. Remember, fast examination is very useful. So we have imagine a situation, you are in the casualty, patient is in shock, and we are giving fluid, but the patient is not responding. Okay, patient is in hemorrhagic shock, patient is shocked, you are giving fluid, patient is not responding. So of course there is hemorrhage, but why the patient is not responding for the fluid resuscitation? So the first step is to identify in the ATLS protocol, in the circulation part, we have to identify the external source of hemorrhage. So external source of hemorrhage is very easy to identify, and you just have to compress it. That is the first principle. But what about internal source of hemorrhage? You cannot see the internal source of hemorrhage. So how you manage? So in there, if the patient is not responding, you have to suspect that the patient might be bleeding inside. There is a dictum that when you are seeing the blood in the floor, you have to see four. The four common sites for internal source of bleeding is the chest cavity, then abdominal cavity, then the pelvis, then the long bones. These are the four common sites. And ultrasound is very useful to see the what is the common this common source of internal source of bleeding. That is the first examination. You have to quickly perform to see the what is the accumulation of blood inside, blood or fluid. So first is the focused assessment by sonography in a trauma patient to find out the cause. So it is mainly useful to see the any case of hemopericardium or any case of hemoperitoneum or hemothorax also. If you are seeing the chest also, that is called e-fast examination. That's a very simple concept. So there are four basic views. So first is subdivide view to assess the any evidence of this hemopericardium that we have already discussed in the echo part. Then second, right hypochondrial part to assess the this hepatorenal space or Morrison's pouch, because this Morrison's pouch is very common site for accumulation of. And the third is left upper quadrant view, that is also splenorenal space. And the fourth common site for fast examination is the pelvic view, also called suprapubic view, to find out any accumulation of blood or fluid just behind the bladder. So the first part is subdivide view for seeing any hemopericardium. We have already seen in the basic echocardiography. So now just we are seeing this hepatorenal or view, that right. This is also called right upper quadrant view or Morrison's pouch. So hepatorenal space is also called Morrison's pouch. Here, the first of all, we have to make the patient supine, and we have to use this curvilinear probe. Place the probe in the mid axillary line. Okay, this is anterior axillary line, then mid axillary, and the posterior axillary. You have to keep your probe in the mid axillary line, around 8 to 11 intercostal spaces, and you will obtain this image. This is normal image. Okay, so this is first of all, you have to see this bright hyperechoic line, that is diaphragm. This is my favorite structure, right, diaphragm. Then after that, you have to recognize this granular structure is liver. Remember, we are using curvilinear probe, so the marker is towards the left side. Then this is liver, and the lower part of the screen, this structure is kidney. So kidney is a dual contrast structure. So in the inner portion there is a medulla, so this is hyperechoic. In the outer portion there is a cortex, gives an hypoechoic appearance. So this is the characteristic appearance of the kidney. So the diaphragm, kidney, this liver and kidney, and this space is called hepatorenal space, also called Morrison's pouch. So this is normal examination. There is no fluid collection here, and just compare. This is abnormal. So you can see in this patient there is abnormal fluid collection or abnormal hypoechoic area in the hepatorenal space or Morrison's pouch. So we have to declare this patient as a fast positive examination. So we have a video for this fast examination.
This is right upper quadrant view of the fast examination. We are using curvilinear probe, and we are seeing the hepatorenal space, also called Morrison's pouch, and we can see that there is no fluid collection within the Morrison's pouch.
So second view is left upper quadrant view, that is perisplenic view. We have to find out is there any fluid collection or blood collection in area around the spleen. Here also patients should be in a supine position. Now we have to keep this probe little posteriorly. Okay, in the left side we have to keep the probe in the posterior axillary line. In the right side it was in the mid axillary, and here the posterior axillary line, and you just have to touch your knuckles to the bed. to obtain this image. And we have to see any anechoic area between the diaphragm and the spleen, and between the spleen and the kidney. So we have a video for that. The left upper quadrant.
This is left upper quadrant view of the fast examination, showing no anechoic area around the spleen, so represents normal fast examination.
So remember, in the right side there was a liver, and here there is a spleen. So liver is a very good acoustic window. So obtaining the right side of the image is easier compared to the left side image. We have a video for fast positive examination. Just before that, yeah.
This is fast positive examination of the right upper quadrant view. We can recognize liver on the upper and left portion of the screen. Then we can recognize kidney on the lower part of the screen, just below the liver. And there is a potential space, that is hepatorenal space, between the liver and kidney, also called Morrison's pouch. And we can clearly see there is anechoic fluid collection within the Morrison's pouch. That represents fast positive examination.
You can see this is left upper quadrant. This is the spleen. This is the kidney, and the superior and inferior part. This is the splenorenal space. There is no fluid here, and in this fast examination, you can see that there is black or anechoic area between the liver, this is the spleen, and the kidney. And also you can see that this is also a very common site for accumulation of the fluid, that is just below the diaphragm and the spleen. So that is also called subphrenic space. And the last part of the fast examination is pelvic or suprapubic view. Here we want to see whether there is any fluid collection just behind the bladder. In the male patient, that is recto-uterine, bladder between the rectum and the bladder. That is also called recto-uterine pouch. And in the female patient, we have to see the area around the recto-uterine pouch, also called between rectum and the uterus. So we have to obtain this image in the this transverse axis and the longitudinal axis. And one trick is that if the bladder is full, it is easier to obtain this image. So that you have to keep in mind. So bladder is also bladder contains urine, so that urine gives an anechoic appearance. So you have to search for extra anechoic for any abdominal fluid collection. So this is in a male patient. We have keep this probe in a transverse fashion, and we are obtaining this image. So remember this, we are using curvilinear probe, and the probe is towards the right side. So this is the right side of the patient, this is left side of the patient. So remember the bladder is full, so you can see that bladder contains urine, giving anechoic appearance in the bladder. So this is the normal appearance. Okay, we have to search for any extra anechoic fluid outside the bladder. Okay, and the same thing, you have to rotate the probe in a longitudinal direction here, and you will obtain this image. This is a longitudinal image. This is the urinary bladder and the superior aspect of the patient and inferior aspect of the patient. You have to search for the any anechoic fluid collection in the longitudinal image. Then you can see that this is abnormal examination, that is fast positive examination. In this is the male patient. You can see that there is extra anechoic area behind the bladder. That is fast positive. And in the female patient, you just have to understand that behind the bladder the uterus is present. So you have to search for the pouch of Douglas, the recto-uterine pouch, any fluid connection. So we have a video for this pelvic view. or
This
suprapubic
is
view.
suprapubic view of the fast examination. We have used curvilinear probe in the transverse axis. Here we have to search for any free fluid collection in the area around the urinary bladder.
So that was a fast examination. Now that there is a concept of e-fast examination, that besides these areas, we have to also search for the thoracic cavity for any fluid or blood connection. So this part we have already described in the detail in the lung ultrasound. So you have to see above the diaphragm also for any fluid collection. So if you are seeing any anechoic area above the diaphragm, you can just declare that fast is positive examination. So remember, fast examination is a very useful in the trauma setting. In our trauma center, every patient has to undergo this fast examination. And the one important thing I want to say, that fast has to be repeated. If the suppose you have examined the patient and the fast is normal, there is no fluid collection. So after some time, if you are suspecting that the blood pressure is falling, that you have to repeat this fast examination. Okay, so fast examination is very sensitive if you are repeating this fast examination. And one more thing, if the fast is positive and the patient is stable, hemodynamically stable, then you can do further investigation, like you can do CT scan. But if the patient is fast positive and patient is hemodynamically unstable, patient is deteriorating, then you have to rush towards the OT for exploration. You cannot waste your time to do further investigation. So the concept is very simple. Fast positive, patient hemodynamically stable, you do CT scan. If the patient is fast positive, patient is unstable, then you have to shift the patient towards the OT setup. Then the third part of this RUS protocol is to see the condition of the major blood vessels. First of all, we have to see the major arteries, that is abdominal or thoracic aorta. So we have to search for any evidence of this abdominal aortic aneurysm, because that may cause rupture and cause of shock. And another is this aortic dissection. So first of all, we have to see this aortic aneurysm. So aortic aneurysm, the clinical triad of this abdominal aortic aneurysm is hypotension, back pain, and pulsatile abdominal mass. Hypotension, back pain, and abdominal mass is the clinical triad of abdominal aortic aneurysm. But this, remember, this is not present in all the cases. And most common size is fusiform shape, and this is secular. So fusiform is the most common, and the most common location is infrarenal. That's the concept. So you have to scan from the epigastrium towards the this bifurcation of the aorta to iliac arteries. In the total area, you have to scan for any evidence of aortic aneurysm. So if you use this curvilinear probe over the abdomen, first of all, you have to recognize this vertebral body. Okay, this vertebral body is a bone, so bright hyperechoic line and hypoechoic shadow. Then artery is situated, abdominal aorta is situated just above the vertebral body. But you inferior vena cava is also situated towards the left side of the screen or the right side of the patient. So remember, this is pulsatile and just above the vertebral body. So this is the abdominal aorta. So this is more circular compared to IVC. And how to measure? So we have to suppose this is the example of abdominal aortic aneurysm. So you have to measure from the outer wall to outer wall. Okay. That there may be thrombus inside the abdominal aortic aneurysm. So there is a concept that you have to measure from the outer wall to outer wall. So normally the diameter is less than 3 centimeter. So we have to measure in a short axis. So if the diameter is more than 3 centimeter of the abdominal aorta, that is the definition of the aneurysm. If the diameter is more than 5 centimeter, then there are the chances of rupture of that abdominal aortic. And also there is a concept that if the diameter is more than 5 centimeter, 5.5 centimeter, that's an indicator of surgery. So 3 centimeter is the cutoff point. Normal, there is a 3 centimeter less than 3 is normal, less and greater than 3 centimeter is the abnormal. So now come to the aortic dissection. So aortic dissection is also very, very uncommon, but very, very lethal and characterized by the chest pain. Here the two important finding, ultrasound finding you can diagnose. One is aortic root dilatation. This is the aortic root. And this is parasternal long axis view, LV and aortic root. Remember this aortic diameter, root diameter is normally 2 to 3 centimeter. But if it is more than 3.8 centimeter, that's an indication that aortic root is dilated. Suppose this is in this image, you can see that the diameter of the aortic root is 5 centimeter. So that is the one feature. And another feature is the sometimes you may find aortic flap. This is intimal echogenic flap. Okay. So two characteristic feature of the aortic dissection is aortic root will be dilated, and you may find there any echogenic intimal flap. So we have a video, last video for aortic dissection.
This is parasternal long axis view to show aortic dissection. We can see that aortic root is dilated and there is a echogenic intimal flap within the dilated aortic root.
Now come to the this last part of the RUS protocol, that is you have to scan this femoral and popliteal veins to see any evidence of thrombosis. Suppose this is the femoral area, so this is the medial and this is lateral. So you just have to keep your probe just below the inguinal ligament, this linear probe, of course. And when you go from the medial to lateral, this is femoral vein, and then artery, and then nerve. There is a formula of V and Van formula, vein, artery, and nerve. Then you have to see this femoral vein area. Normally, it should be collapsible. If there is no collapsibility, that is also a collapsibility test. If it is not compressible and there is a thrombus inside, then that's an DVT positive. And in addition to this right ventricle dilated, and in addition to that you are seeing this DVT positive, that's a strong suspicion of this pulmonary embolism. So we have just completed this RUS protocol of fast examination. So we have assimilated various information. Just to summarize all the information to find to make the things easier, I have made this this chart. This is the RUS protocol. We have to see this first pump, then second tank, then pipes. Then there are different kind of shock: hypovolemic shock, cardiogenic shock, and obstructive type of shock. In obstructive, there are mainly three things: tamponade, pulmonary embolism, and pneumothorax. You just scan heart, lung, and IVC and the tank area, and you will come to closer to the your definitive diagnosis. First of all, see the pericardium. Either if you are seeing any effusion, there is a tamponade. So okay, so first of all, see what's the feature of hypovolemic shock. Okay, hypovolemic shock, the contractility will be hypercontractile, and there will be a small chamber size because of decrease in the volume, and the IVC will be small, very flat, and lesser size of the IVC, but the collapsibility will be high, greater than 50%. Okay, we are discussing hypovolemic shock. So you may find E positive. That may be the region of hypovolemic shock. Sliding sign is normal, and there is no V lines. And sometimes you may find abdominal aortic aneurysm or aortic dissection. That may be the region of hypovolemic shock. Now come to cardiogenic shock. in the case of cardiogenic shock, the heart will be hypocontractile and sometimes dilated also. Then, of course, the IVC will be dilated and full, and there is less than 50% chance of the change in the respiration. And in the cardiogenic shock, the sliding sign will be normal. But you may find pulmonary edema because of cardiogenic shock. You may find several B lines if the homogeneous bilateral signs of cardiogenic pulmonary edema. That's a feature of cardiogenic shock. In case of obstructive shock, first concentrate on tamponade. If you are seeing the pericardial effusion, that's, and also there is a diastolic collapse. Also, the IVC is dilated or distended. That's a sign of tamponade. Rest all the things will be simple. Tamponade means effusion, diastolic collapse, IVC dilated. Take an example of pulmonary embolism. Right ventricle will be dilated. There will be D-shaped septum, or you may find cardiac thrombus. Then the IVC will be distended, and you may find DVT sign positive. That's all the signs directing towards the pulmonary embolism. In case of pneumothorax, heart will be normal. Because of obstructive shock, this IVC is distended, and there will be absent lung sliding, and you may find lung point. That's a sign of pneumothorax or obstructive shock. So you have the knowledge what kind of shock it is, then you have to move for the management. Suppose there is a hypovolemia, then you give fluid or fluid resuscitation. But if there is a cardiogenic shock, then you have to give inotrope. If there is a tamponade, you have to do pericardiocentesis. You have to, if there is an embolism, you have to do this fibrinolysis or thrombolysis. If there is pneumothorax, we have to do needle compression or chest tube placement to treat the patient. So all this completes this overall basic echocardiography and the Ross examination. So the basic concept is over now, but sometimes the residents are also interested to know how this contractility can be estimated. So that is so now we are going to estimate the contractility function or estimate the ejection fraction. Remember, this is not a part of basic echocardiography. This is a little further. So one thing I want to just discuss, that why this contractility or ejection fraction is important to us. It is important for every clinician to know the status of contractility, that whenever we want to give fluid, we have to assess this, that the condition of the contractility, and that how much fluid can be given before the development of the fluid overload sign and symptom. How much fluid that can be safely given to a patient. Suppose patient with a poor contractility, we cannot give too much of fluid. Okay, so in that condition, if there is a poor contractility, we have to give inotropes. So assessment of contractility is very, very important when you to assess the fluid responsiveness, when you want to give the fluid to avoid any signs of fluid overload. So there are several techniques for assessment of this stroke volume estimation. Like one very popular is fractional sorting. Here we are using this M mode, and the second method is EPSS. In that also we will use M mode technique, and the third method is the product of VTI and area that gives a stroke volume. And the last part is Simpson method. The experienced cardiologists do that Simpson method. So Simpson method is a little bit difficult and cumbersome to that. But besides that, also there are some simpler techniques, that fractional shortening, then EPSS, and then VTI method that intensivist can perform and have a rough idea about the contractility. This is the fractional shortening technique. You can see that we have to assess the first obtain this parasternal long axis view, and we have to use A mode. So the cursor should be placed just beyond the this mitral wall, and you will obtain this uh, A mode tracing. So remember, this is an interventricular septum, and this is the cavity of the left ventricle. So this is the systolic diameter, and this is the diastolic diameter. You have to assess what is the end. You have to calculate, place your cursor to calculate what is end systolic diameter and diastolic diameter. So the fractional shortening means end diastolic diameter minus end systolic diameter divided by and diastolic diameter. So in this image, you can see that end diastolic diameter is 3.47 and end systolic diameter is 2.46. This is end diastolic and systolic. So by calculating this formula, you can see the fractional sorting is about 29%. So this is the method you can estimate the contractility of the patient. Normally, the above it should be above 30 to 40%. You can see that this is a good contractility, this is the poor contractility. In this good contractility, you can see that the fractional sorting is about 62%. This is the end diastolic diameter, this is end systolic diameter. There is a good percentage sorting from the diastole to systole. Take an example of this heart. This is end diastolic, this is end systolic. There is less percentage change. So this fractional sorting about 27%. So this is the one method you can calculate this contractility. Then this is my favorite technique. This is called E-point septal separation. So now again we have to obtain this parasternal long axis view, and this is mitral leaflet, anterior cusp of mitral leaflet. Then A mode cursor should be placed just at the tip of the mitral leaflet, and you will obtain this picture. You can see this is the movement of the mitral leaflet. So there is a one peak that is called A wave, and there is another peak that is called A point. This is E point, this is A point. So we are interested in the E point. So E point, and this is the septum. So the distance between septum and the E point, that is called E point septal separation. So remember, we have already discussed the movement of leaflet, anterior leaflet is very important. Normally, in the normal heart, in the ventricular filling phase, this leaflet touches the ventricular septum. So in the normal contracting heart, the distance between septum and this valve is very, very less. But if there is a poor contractility, this distance will increase. So this E point septal separation, normally this is less than 7 millimeter. That is a good contractility. But if it is more than 10 millimeter or more than 1 centimeter, that's a sign of poor contractility. So this is very simpler technique. You just have to keep your cursor over the mitral wall and measure the distance between the septum and the E point, and you will get a rough idea about the contractility of the heart. This is very, very simpler technique for this ICU setup. And the third technique I want to describe, that the stroke volume into area stroke volume calculation. So if you remember the physiological aspect, so what is the main aim of the cardiovascular system? What is the main aim? The main aim of the cardiovascular system is to maintain organ perfusion and tissue oxygenation. That is the main goal. So our total cardiovascular system to achieve the organ perfusion, and the organ perfusion is dependent upon the blood pressure, and the blood pressure depends upon the cardiac output. Okay, cardiac output, and the cardiac output is equal to stroke volume into heart rate. Okay, so naturally the main the parameter of interest is the stroke volume. If you are able to estimate the stroke volume, then it is very important to know if the stroke volume is good, you can give fluid. If your stroke volume is not good, you have to give inotropes. So a stroke volume calculation is very important. You can see that the cardiac output is equal to a stroke volume in the heart rate, and the stroke volume can be calculated by one formula, that is area into VTI. So remember, what is a stroke volume? So a stroke volume is amount of volume ejected in one heartbeat. Okay, cardiac output is amount of blood ejected in one minute, but a stroke volume is the volume of blood ejected in one heartbeat. So a stroke volume is a volume. So imagine a concept of cylinder. Cylinder, the blood ejected from the heart rate in a one beat. So imagine as you have to measure the volume of the cylinder. So naturally this is a volume. So volume is equal to area into length. So VTI is not is length. Actually, this is a stroke length. So area into length is equal to volume. So remember that this LVOT area is a cylinder, then the things will be easier. So it is very important to helpful assessment of shock and to monitor our intervention. If the stroke volume is increasing, that means our intervention is working. So first, we have to measure this area and VTI. So the area we have to measure and the LVOT area. So we have to measure this diameter, then the area can be calculated, and this is the VTI calculation. See here. So remember, for the area calculation, we are using parasternal long axis, and we have to measure this diameter, and the diameter gives an area is equal to pi r square or d square into 0.85. And for calculating this VTI is a stroke distance. We have to obtain the apical 5 chamber view. Okay, so stroke volume is equal to area into VTI. See, first we have to calculate the area. So area, we have to obtain this parasternal long axis view and measure the diameter of the LVOT. So if you are able to measure this diameter, then with the formula of pi r square or this 0.785 d square, you can calculate this area. So area is very, but remember this area should be measured accurately. Otherwise, error can be incorporated. So you have to avoid while measuring this area. So if you are committing any error, that will be squared up. Okay. So remember that your area should be calculated correctly. Then second point is the VTI calculation. So VTI is nothing but the distance. You have to obtain this apical 5 chamber view. Then you have to use pulse Doppler. So pulse Doppler is applied to this LVOT area of the 5 chamber view, and you will obtain this flow velocity spectrum. Whenever you apply this pulse Doppler, you will get this spectrum. This is velocity into time. Okay, this vertical axis represent velocity, and this transverse axis represent time. So naturally, this velocity time integral. That's why it is called VTI. So remember, this is the transverse axis is the time, and this vertical axis is the mean velocity. So that's why it is called velocity time integral, and that's gives an VTI. You just have to calculate this stress this area with your ultrasound machine, and the machine system will automatically give you this VTI. Okay, suppose taking this example, this VTI is about 23 centimeter. So VTI is a length, that's why it is the unit is in centimeter. So normal VTI is about 18 to 22 centimeter. Okay, so VTI is you just have to multiply this VTI into area. That gives a stroke volume estimation. So normally VTI is 10 to 22 centimeter. If it is less than suppose VTI is 10, so you have to suspect that there is a poor stroke volume. So that completes this today's class. So to summarize the things, we have 4 basic views for sound, personal long axis, short axis, apical fourth chamber, and subdivide. And we have discussed this RUS protocol for the immediate diagnosis of the shock patient. First assess the pump, that heart, then IVC in first examination, then the examination of the pipes. Then that completes the basic concepts of the shock management and basic echocardiography. If you are interested to know how this stroke volume is estimated, there are some simpler techniques, that is fractional shortening, then EPSS, mitral valve movement, then VTI calculation can be done to estimate this stroke volume. Thank you so much.
Thank you, Dr. Niraj. That was a wonderful presentation, and which went on almost for 1 hour 35 minutes. All our users, and they were very patient, and they were listening throughout your class, and very good comments have come. There are
Okay.
not many questions, and you made it very simple and very interesting. My one suggestion would be that the ejection fraction calculation, everybody wants to know it, though it is not needed, as you said. Eyeballing and quick assessment is more beneficial, particularly when you are using it as a point of care ultrasound.
Okay.
Maybe we have finished most of the classes except airway ultrasound now, I think, right?
The airway ultrasound, the airway is remaining. So we'll cover.
Remaining, and yeah, next time you can make some of these videos of calculating the ejection fraction live,
Oh, okay,
and you
okay.
can show it, because airway ultrasound will not take much time,
Uh,
maybe around 20-30 minutes, so you can make these videos and make them understand also.
okay. Yeah.
And everybody has given a very good suggestions, good compliments for you, for your wonderful videos and the way you present it. Thank you, thanks a lot.
Okay.
Thank you, Niraj. It was a very wonderful presentation. And I think
Yeah,
because this is a recorded session and the people will have the opportunity to come back and review
yeah.
the videos. And I think with such wonderful videos and presentations, I think the more and more they go and do in their own patients, then it will become very familiar to them. Yes, Manish, your comments?
This was actually a very concise and at the same time very extensive coverage of 2D echography and other fast and other uses of ultrasound, which is very useful in clinical scenarios, especially in emergency and critical care. So that was a great job done in very short time.
Neeraj,
Yeah.
just only one question. In sometimes in some patients we struggle to get the images, especially if the body habitus is not a bit obese or okay. Even IVC sometimes it's very difficult to get. So are there any quick fixes for this, or it is better to have a prefixed program to screen the echo and IVC? Of course, echo in all the machines it will be there, but I think only in the recent machines the ER mode, the fast mode, and the IVC modes are coming. So any quick fixes to obtain a good quality ultrasound?
Okay. So remember, if you're talking about this basic echocardiography, there are four views: apical, this long axis, short axis, apical fourth chamber, subdivide. In a spontaneously breathing patient, it is very difficult to obtain this subdivide view. Okay, so we have to remember that in a subdivide view is very difficult to obtain, because we want to see through the abdomen. So in the spontaneously breathing patient, sometimes is in obese patient or abdominal is full, and this intestinal content gases, then obtaining this subdivide view is sometimes very difficult. So just I'm saying that while in ventilated patient, when patient is on ventilator or mechanically ventilation in ICU, then because of ventilation, this the chest part is little bit on a downside. So heart will be closer towards the abdomen. In the ventilator patient, this obtaining this subdivide view is little bit easier. And that's the one thing. And second point is sometimes a pica four chamber is also difficult to obtain. So just make you the patient into left lateral position, then you will find this is easier. And you have to accept that in every in a particular individual, all the images will not be good. So that's why I want to stress that you have to develop your capacity that you can obtain all the images. You have to master with the ultrasound that you can obtain all the views of the ultrasound. In few patients you cannot obtain this subdivide view. In few patients you cannot obtain long this apical four chamber view. But remember, this the parasternal long axis view is I think I can obtain this. Everyone can obtain this in more than 90% of the cases. And parasternal long axis is very useful image. You can get an idea about the pericardial effusion. You can get an idea about the contractility. You can calculate the fractional shortening. You can get a mitral wall motion. You can get EPSS. You can differentiate between pericardial effusion and pleural effusion. So just I'm sharing that parasternal long axis is very easy to obtain, and it can be obtained in more than 90% of the cases. Regarding this IVC, of course, in this you have to keep your probe in in the subdivide in the longitudinal direction. But if you're not getting this IVC, one technique, another technique is that you just right upper quadrant or left upper quadrant the view which you are getting for hepatorenal or splenorenal space. If you keep your probe slightly on the downward direction, you can also get an IVC from that area also. So in
Yes,
that
true.
mhm. So IVC examination, you just have to look the IVC whether it is collapsed or whether it is full. You don't have to calculate so much. If it is collapsed, then you have to a strong suspicion that there is a fluid deficit. You just image your IVC. If it is collapsed, then give fluid. If it is not, if it is dilated or if it is full, then go try to avoid giving fluid. So there are and one technique I just want to share that I have already learned after some time. This suprapubic view to examination of the bladder. So when you keep the probe just straight, then you will not get the suprapubic. You have to first palpate this pubic symphysis. Then you just have to tilt your probe on a downward direction towards the foot end side. Then immediately you will get this bladder image. There are few tricks to obtain this good image.
I
Yeah.
think one session we'll have on troubleshooting. So
Yeah,
that
yeah,
viewers because once they see the beautiful images, they'll just go and put the probe. They will not get such beautiful image. Then they'll get depressed. So what we will do is in one session we'll have troubleshooting actually.
Okay,
So
okay. I will try to do that.
yeah, that will be
How to
interesting.
obtain a good image.
Yeah. So like Prasanna said, airway, and another thing is that we have to show few videos of procedures also, like Prasanna
Okay,
said,
okay.
for procedural arterial cannulation, IVG and IJV
Yeah,
and
yeah,
subclavian
yeah.
cannulation.
We
Yeah,
can
yeah.
combine this airway and ultrasound guided cannulation.
Yes,
Yeah,
yes.
Yeah.
yeah, yeah.
Yeah.
Okay,
Okay.
Dr. Niraj, thank you so much for this
Okay.
wonderful discussion.
Mhm.
I think we'll meet in another classroom. And thanks for watching, and thank you for all your support. Thank you.
Okay.
Thank you.